I think over the last years we have made some progress in sorting out which patients benefit most from anti-EGFR treatment. It's not of the very last years, but I think the knowledge has not been widely accepted that it's the best treatment for a subgroup of patients with left-sided RAS wild-type patients. When I say subtype, then it's especially related to the most important step in this year, where we have seen the results of the Breakwater trial that added a third group, the BRAF mutant patients who are a separate strata and benefit significantly from the targeted therapy. And there is a very high likelihood that patients who have HER2 amplification need another treatment too, and there are the first-line trials currently recruiting. When I have spoken on metastatic colorectal cancer, I have to add that it was related to the microsatellite stable patients, because the most prominent step during the last decade was probably to detect that MSI-high patients benefit from immunotherapy, and that we should regard this subgroup as a specific disease who deserves a completely another treatment, where we can cure metastatic patients with medical treatment alone. This is a wide topic. I think what we know already is that we can replace tissue testing for RAS-BRAF by ctDNA testing at time of diagnosis of metastatic disease. There are some issues that we should consider when we take the blood sample. The patient must have tumor, that we have a high amount of circulating tumor DNA, and then in this case this technique is quite sure. However, mostly we can just use the tissue testing because we have in colon cancer mostly enough tissue. What we have seen in some trials, for example FIRE4 paradigm, is that liquid biopsy testing at start of first line or second line therapy has a higher sensitivity to detect mutations in ctDNA and in other alterations like BRAF and so on. This might be related due to tumor heterogeneity. Another explanation could be that different cutoffs or a different quality was used when there was a central testing with ctDNA compared to local pathologist results. And we have seen differences in central versus local pathology also in other randomized clinical trials, like for example MSI-high trials, like the HAV trial or the Atomic trial. So in this situation it's quite sure, so you could get a lower sensitivity if you take the blood sample at time of a very good response of the patient, or when the patient is not yet progressing, then you can get false negative results. And blood sampling should be done in certified tubes or should be immediately centrifuged, so it's a little bit a sensitive issue. If we go for detection of minimal residual disease, I think this could be a major step forward to select patients for adjuvant treatment in the next future. At the moment, I think it's rather a selection for or against any adjuvant treatment because we have not too many options to escalate and de-escalate adjuvant therapy in colon cancer. There are some trials at the moment ongoing, especially in stage 2, to escalate for low-risk stage 2 patients. We have seen what will be the results, because we have to find out which patients actually benefit from adjuvant therapy. Some patients progress extremely early before they can be randomized or could be randomized. And in my personal opinion, the likelihood that we will see a signal is quite high in this situation. It might be that we can, in the later future, perhaps skip adjuvant therapy, but of course it would be much more interesting to learn whether we could apply an additional, perhaps targeted therapy in patients who are still ctDNA positive after adjuvant therapy, because they will have a progression, quite sure. I don't believe that it will be a quite early standard of clinical practice, because we are lacking the drugs. So a situation where we have specific inhibitors of resistant mutations, like next generation EGFR inhibitors as in lung cancer, or estrogen receptor degrader like in breast cancer, we are unfortunately not in this situation. And in lung cancer we learned that the drug that we had given in the later line, when we have detected the resistant, that it was even better to start with this drug upfront. Therefore, let's assume that, for example, a pan-RAS inhibitor would make higher toxicities, and that we would have a KRAS G12D and C inhibitors available in the daily clinical practice. I could imagine that it might become a strategy to treat patients with such a specific KRAS inhibitor and then switch to a pan-RAS inhibitor as soon as there are the first resistant mutations. But this is an outline of a trial where we need the drug first, and therefore I think it will not be in the very next future. Yeah, so I think we will learn more on immunotherapy. This is very likely. We might learn in ctDNA treatment selection for or against adjuvant therapy based on ctDNA. I think we will get more knowledge on super selection of patients in first-line therapy, that we detect resistance mutations and that we could increase perhaps the quality. And for the daily clinical practice, I think it's as important as to use these very new tools to focus on high quality on the therapy that we are actually giving nowadays, and that we don't make mistakes. And artificial intelligence might help to detect signals in tissue or patterns to detect resistant mutations, especially if we combine data from tissue testing with clinical data and liquid biopsy data, because these patterns might be too complicated for humans to identify. But remember, we need very large data sets, and we need data sets for confirmation, and this will therefore be a topic where we'll get some signals quite soon, but it might take some time until we have confirmatory data. So ESMO is a huge success story, especially over the last 10-15 years. It has taken a huge in development, in forming a society, in developing a lively congress, which is very friendly and attracts many people around the world, especially from Asia too. So my city is quite close to Berlin, where the ESMO Congress this year. So therefore I welcome all people to come to Berlin to the next ESMO Congress, and I can only say happy birthday.